Hello, and welcome to the Preceptor Pulse, where we give busy teachers in medical education quick tips for guiding the next generation of physicians in rural and community health.
On today's Preceptor Pulse, Drew Keister and John Hayes discuss their experiences using AI in residency teaching. Artificial intelligence is a resource in the practice of medicine that's grown tremendously in the last few years, and it promises to expand even further in the next decade. It is finding use in scribing, evidence-informed medicine, and medical education, just to name a few examples. Today, Drew and John share details of how AI can be used for preceptors in rural and underserved settings. We should note that John used AI as he formulated the questions for today's conversation, yet another excellent use of this technology. John, tell us a little about yourself and about your interest in AI.
Hi, everybody. I'm John Hayes. I am the program director for the Green Bay Family Medicine Residency here in Green Bay, Wisconsin. I also sit on the Society of Teachers of Family Medicine's National Artificial Intelligence Task Force. And sort of the charge from STFM is that we help teach doctors how to use AI tools specifically in education. So when Drew reached out to me and wanted to interview me for this, I was really excited. Happy to answer questions and try and get more people to use these amazing tools.
Awesome. Thank you, John. So I'll dive into our questions. AI tools can be powerful aids in rural and underserved settings where specialists are scarce or difficult to access. How would you teach residents to use AI for decision support without them becoming over-reliant on AI or losing their own critical thinking skills?
I think this is a really interesting question. If you look at AI, some people are saying, our doctor's going to go away? Are we all just going to be talking to the algorithms all the time? And I don't think that at all is the case. I think that in the age of AI, specialist physicians are going to become a lot less necessary. And the tools that we have at our fingers to answer complex questions just completely unheard of. So it's specific examples. You have a patient, you're out somewhere rural, getting him into a cardiologist might take months. They would have to arrange transportation. It would be a giant mess. And by the time the patient gets to the cardiologist, they might not even know what the question you asked was. I've definitely been there before in my own career. Well, now we have open evidence. So you can literally type in a very complex question. I have a 55-year-old person with coronary artery disease and a history of a GI bleed. Is it safe to do Brilinta and aspirin? Or what do you think about Xarelto in this case? Things that you would send somebody to a specialist to answer. I don't think you're going to ever really need to do that moving forward. You can just ask those really complex niche questions to the AI.
Right, absolutely. And I think open evidence is a great example of a resource that's easy to use, that people can access for free. And so talk a little bit about when you're working with residents and how how you show them to use that tool.
So I think residents' use of open evidence is a really interesting problem. That back in the old days when we had books, or even after that when we had UpToDate, in order to answer a clinical question, what you had to do is skim or read like a book chapter or skim a whole UpToDate article to find that one answer. And what was good about that is that you got a lot of background reading and background resources. So what I've found in a very AI-friendly family medicine residency is that I have residents that know the answers to teeny tiny minute questions that they're asking the AI, but they don't get the big picture.
Right. Okay.
So my advice to residents, if you're on the go and you need a clinical question answered right away, use open evidence, right? Paste in the pathology results or the radiology results, let it help you build differentials, let it answer complex questions. But don't let open evidence teach you how heart failure works. They have review articles for that. They have actually a completely different AI tool would be a way better way to learn things. So what I teach my residents to do is take review articles that you like, journal articles from reputable sources, book chapters even, and a different AI tool, I have them upload all of those resources to Open Evidence, to Notebook LM. So Notebook LM is a Google product. You can put in up to 300 sources and have it synthesize all of those sources. Then you create a highly reliable explainer. Open Evidence can create podcasts for you. It can create video explainers. It can create slide decks. It can create quizzes. So,
And when you said, was that Open Evidence or is that the other?
ah,
That's right.
so Notebook LM
Right. Okay.
is a way better resource for teaching residents general background. What you can do is you can upload up to 300 different sources. You can upload YouTube videos, journal articles, book chapters, photos, Excel spreadsheets, audio recordings from maybe your own didactics when you had somebody come and talk. And what Notebook LM will do is it'll synthesize all of that. It'll create these amazing resources for you. Podcasts that you can actually interact with and you can ask it questions. It can create video explainers like in 5 minutes, or you can make it go in deep mode and create a 20-minute video to really give you deep knowledge. I think the era of telling somebody to go read a book chapter or even read that up-to-date article, even that's a little bit obsolete now. Like upload all of the materials that you want to learn something, upload it to Notebook LM and have an iterative conversation and use different mediums to teach you a topic.
Right.
But you
Yeah.
want
So
to
it's
use
really, it's
background.
helpful because it lets you have the conversation with the AI then, right? And
Right.
so if you need clarity, if a resident or even you as learning background on something needs some clarity, you can ask the question and the AI can help to fill in the answer.
And residents are tired too. Like we often make residents work 60 to 80 hours a week, and asking them or expecting them to go home and read an article and then present that back to you, I think sometimes is a big ask. But they might have a 30-minute commute, especially if they're in a rural GME residency. And they could take that article, turn it into a podcast, and listen to it on their way home, and even interact with that podcast. So there's just better ways to learn, and this is just opening up different modalities to people.
Absolutely. I love it. So I want to change gears and ask about ambient AI. So the practice of medicine relies on deep patient trust. So how do you use ambient AI for like automated scribing to actually improve the patient connection? And how would you model that for a resident who's skeptical of using this technology in the exam room?
So this is really interesting. There's a big debate going on in graduate medical education about how we use ambient AI scribes. Um, I will say that I'm on the very early adopter fringe of program directors. From day one at my residency program, every one of my residents gets access to an ambient scribe. We use DAX, a Microsoft product, but there's a million different products out there that are HIPAA compliant that you could use. I teach the residents how to use that ambient AI scribe. I have them look at their note and say, oh, it's created this long verbatim thing. Like, how do we go in and customize the prompt so that it's bulleted or it is the way you like it? Like, do you like this note? Are you spending too much time editing your AI scribe note? Then you're doing it wrong. Let's shrink that down. And what effect does that have? There's an argument to say that the residents are never going to learn how to write notes because the AI is doing it for them. I don't think that that's an evidence-based argument. There is not a shred of evidence to say that our residents that have used AI scribing are worse doctors in any way.
Right.
What I think is AI is helping them structure a note, and if one day the building gets struck by lightning and the AI robot's broken, they're gonna know how to write that note.
Right. Yeah, and
So
one of the
if
things I remember from when we implemented EHRs is there was this concern that having templates within the EHR people wouldn't remember review systems or wouldn't remember how to ask questions, wouldn't learn how to kind of focus it. And I think for most of us, those concerns have sort of gone away. It sounds like you're saying that you think that that's going to be true for ambient AI technology as well.
I tell all my residency graduates, don't work for an organization that doesn't have ambient AI scribes. That means they don't care about you because
Mhm.
the impact that it has on patient care is really profound and also on burnout, right? The fact that my resident can look a patient in their eye the entire time, um, have a beautifully detailed note, and not have to spend hours of pajama time or having me harangue them to do their note or um, overthinking, as residents often do, how to structure their note and what information to put in there. There's all this analysis paralysis that happens. None of that happens anymore. Do they miss something? I don't think so because I still do the job as a preceptor, right?
Right.
I'm I'm still challenging their clinical reasoning. I'm still asking them questions to make sure they understand the patient care. And in fact, I think I have more time to ask them questions and challenge their reasoning because they're not stuck typing in a room. They're out here talking to me.
Yeah.
And the patients like them and maybe even might be retained better because now this doctor is looking me eye to eye like a human and they're not typing away in the corner with their back to them. So I think
Awesome.
ambient scribes are great for education, and I encourage people to let residents have access to them as soon as possible.
Great. Um, One last question. So AI has the potential to simplify complex medical information for patients. Can you describe how you might use AI to improve health literacy for our underserved or rural population while ensuring information remains accurate and unbiased?
Right. So whatever EHR you're using, I guarantee it has patient handouts built into it.
Right.
I also can guarantee that those handouts are not very good, right?
Mhm.
They're they're not the appropriate reading level for your patient. They're giving advice that is generic and not necessarily specific for your patient. Um, they populate a note, check a box for the EHR, and then go promptly into the trash. So there's an AI agent that I recommend that all of my residents use to create patient information or patient education, and that's called Perplexity. Um, so what Perplexity does, it's like Gemini or ChatGPT, but Perplexity searches the web and is really an expert in synthesizing information and citing it from specific resources. All of the patient education resources, they're already out there. Perplexity is trained on, and it can create really customized patient education handouts for your patient. So I have a um, rural farm worker with only access to canned goods with chronic kidney disease who speaks Spanish at a fifth grade literacy level. I would like to create them a handout on healthy eating with all of
Right.
these constraints. There isn't a handout in the world that's been written for that specific situation, but you put that into Perplexity and it will spit out a perfect handout that you should read for sure, and make sure that it's accurate. But it's so much more patient specific and so much better that I think it's really helping us provide better education. And the resident learns by reading it, and then explaining that handout to their patient that they also learn health literacy that way. The prompting matters. If you just tell Perplexity, hey, make me a handout on lower back pain stretches, it'll make a
It's gonna be
generic
the same
handout that
as
may or
right.
may not be appropriate. But if you say, I have a patient with that can't read, that needs a visual only handout for lumbar back pain, it can do that. It'll create a ton of pictures. It'll link you articles. It much better resource overall.
Wonderful. Well, that's great. I just want to go back and just for, people's remembering, talk about the three products that you've talked about want to make sure first that you don't own stock in these products, that you don't have any financial, kind of conflicts of interest around them. I think I remember you saying at your talk that these are things that you use because you found them to be good quality material.
So these are all things that I use as a overworked program director who is just trying to make ends meet. If you're out there listening to this, you probably have 40 hours of work in a 24-hour day, and AI has allowed me to live my life and be a better father and be a better program director because it's helping automate some of these really resource intensive tasks. So yes, I'm an early adopter. Nobody has paid me anything. I guess technically I do own some Alphabet stock, but I don't think that is going to inform my bias here. So the resources I explained. If you have to answer a specific question, you have pathology results, you have radiology results, you want to build a differential, you're trying to send somebody to a specialist and you don't think the specialist will accept them or their insurance won't work. Open evidence is a great place to generate an answer to your question. And what's great about it is it also links to articles. So you don't necessarily need to just trust what it's telling you. You can click on the individual articles and read it for yourself and verify. But it does a really good job answering clinical questions. So that's number one. Use open evidence to answer specific questions, but not do general background. If you want to learn how to care for people with coronary artery disease or diabetes or what I recommend you do is you gather a bunch of resources, put them in a file. Let's find a bunch of review articles from sources that you trust, like the American Academy of Family Physicians or American College of Cardiology, American Diabetic Association. Put in a 300-page guideline that you would never be able to read and maintain consciousness. What you could use Notebook LM for is you put all of those resources in Notebook LM and it will synthesize beautiful explainers for you in the modality that you like. Like it could do podcasts, it could do visual, it could do written summaries. You can ask it questions, either verbally or via typing. And instead of it's better than using like ChatGPT or Gemini, for example, because Notebook LM will answer questions based on the stuff you gave it and nothing more. It's not going to hallucinate answers. So it's a lot safer in that regard. So Notebook LM, highly recommend to teach you things, general background. And the third thing I talked about, ambient scribes. There's a million of them. I don't.
Oh, yeah. Actually, Perplexity was the other resource that you kind of highlighted.
Yeah. One thing about ambient scribes.
Oh, please, yes.
Is that there are free versions of it. So even if you don't have your healthcare organization has not signed on quite yet, there are HIPAA compliant free ambient scribes. Doximity GPT is one example. So the Doximity, if you're a physician, you can have a Doximity account. Heidi is another. They have a free version that's ad supported. It's great and it's HIPAA compliant and it can be an ambient scribe for you just using your cell phone. Okay, and the last one is you want to create a patient handout, a recipe, a detailed patient guidance about what to do, and you want to titrate it to a patient's literacy level and specific circumstances, language. My recommendation is to use Perplexity. Perplexity is a great resource. You be as specific as possible about the characteristics of the patient, and it can give you really beautiful, detailed handouts for whatever situation you're looking for.
Wonderful. Thank you so much for this conversation. It's been really helpful. John, tell me, what one takeaway do you want preceptors to have from our conversation today?
AI can be scary. It's easy to say residents shouldn't use AI. I'm going to outlaw it. Because I want them to learn it a cappella the old way. That's just not a real world solution to this evolving world. I recommend preceptors experiment with the things I talked about. And I didn't go to college for any of this stuff. I just play around with it. The more you work with it, the better you'll get at it. Highly recommend you just try it out.
I was going to say the same thing. I think my biggest takeaway is just if one of these resources that you haven't used, just try it. Set aside 10 minutes and try using one of these things on your own. And what I have found when I have done that, when I've taken the 10 minutes, is that I just want to have more. I want to try some new things. And so give yourself the time. You do not need to be a computer expert to do this. You don't need to be a kid who's 20 years old. All of us can learn this, and it can make our lives better. So thank you very much, John. Really appreciate you being with us today on the Preceptor Pulse.
Thanks for having me. This was really exciting.
Thank you for joining us for the Preceptor Pulse. We hope this was a helpful resource for your teaching role.